Welcome back. For this segment, we're going to interpret the difficult carotid examination. In this presentation, we're going to review a number of difficult cases. We're going to look at calcified plaque, inflow lesions, as well as outflow lesions. We're going to review a near total occlusion, discuss compensatory flow, and look at some difficult cases where there'll be a discrepancy between the diagnostic criteria. Let's start out with this case. This patient presents with a history of syncope, and we have a color Doppler image showing calcified plaque in the carotid bifurcation. You can appreciate the shadow from the plaque and the posterior acoustic shadow. And we can see that there is relatively homogeneous flow in the internal carotid artery. The first sample is from the distal right common carotid artery, and the flow velocity is 37 centimeters per second. What do you think, normal or abnormal? Abnormal. The velocity is low. What about the upstroke? Is that good? Looks like a pretty good upstroke. So the inflow is probably okay. So here's the waveform from the internal carotid artery distal to the plaque. Okay? The peak systolic velocity is 124 centimeters per second. So I ask you, you think there's a significant stenosis in that right internal carotid? What are the clues here? Anybody? Okay, we look like we have a tardus parvus waveform. All right, so how do you grade the right internal carotid? I think it's less than 50%. Remember, the velocity is 124. Is it 50 to 69% stenosis? Greater than 70%? Is it occluded? Or don't ask me, it's your case. And I'm sure at this point in the day, the answer is number 5. Okay, so let's analyze the case. Peak systolic velocity in the right common carotid artery is low. It's 37 centimeters per second. As we analyzed it, we said that there was a good upstroke, although low velocity. The ICA outflow demonstrates an abnormal shaggy waveform with a delayed upstroke consistent with a tardus waveform. And in fact, due to its appearance, you might even say that it looks like post-stenotic turbulence. So how do we address a case like this, where we think that there's something more than the peak systolic velocity suggests? Well, certainly we want to get a better look in the region of the plaque. And that's what I did in this particular case. Went in, re-examined the patient, scanned around the plaque, and found an area where I could get a peak systolic velocity that was over 300 centimeters per second. So clearly it's a severe, greater than 70% stenosis, although the velocity itself in the distal internal did not suggest it to be so high. Here's the MRA in this case. And remember, when you have calcified plaque and it's difficult to see the lumen and you're concerned that you might be missing a stenosis, check additional acoustic windows. Scan around the plaque, above and below the plaque. And if you're still unsure, then it's important to request correlation. Ask for another test. Here's our next case. This patient presents with a history of a TIA. And I'm presenting 2 waveforms, one from the right internal carotid, one from the left. The peak systolic velocity on the right is 33, and the peak systolic velocity from the left internal carotid is 101. So clearly we have some asymmetry here. And again, I always ask you that you compare both sides. Sometimes it'll bring out an abnormality you may not have suspected just by looking at the vessel by itself. Which do you think is the abnormal side? The right side. That's correct. The right side has the low peak systolic velocity. It's only 33. You notice there isn't a big difference between systole and end-diastole in that case. The waveform from the left has a normal flow pattern, normal profile, normal velocity. So the problem is on the right. So the question is, where is the problem? Let's take a look at one more piece of information. Here's the right vertebral. Normal or abnormal? It's abnormal. We know that the right vertebral artery waveform should resemble the internal carotid artery. And it should be flow in one direction with low resistance pattern. This is a bidirectional waveform. And what does that suggest? Right, that there's proximal lesion. We said before when we saw reversal of flow in the vertebral, it reminded us of a subclavian steal. But in this particular case, we have two pieces of information. We have abnormal flow in the right internal carotid artery, low velocity, and we have abnormal flow in the right vertebral artery. If we assume there's one lesion, where would it be? Would it be at the level of the aortic arch, the innominate artery, origin of the common carotid artery, carotid bifurcation, or distal ICA? Any takers? The innominate artery makes sense. As we analyze the case, we notice there's decreased velocity in the right internal. We also suspect that there may be a delayed upstroke and it doesn't have a nice crisp systolic rise, suggesting an inflow lesion. The flow is low, small, parvus, with a late upstroke tardus, whereas the left ICA is normal. And that's very important because it isolates the problem to the right side. It's not a problem of the aortic arch. The biphasic vertebral artery signal also speaks to a proximal lesion. The one location that ties this all together is the right innominate artery. And here is the MR angiogram on this patient that we requested because we knew the lesion had to be there. Right? Abnormal flow in the right internal and the vertebral, both supplied by the innominate, and there's the stenosis right at its origin. All right, you guys are doing great. Let's keep it going. Here's a patient that presents with dizziness. Okay? Now, thinking caps on. Here are the waveforms from the right side. I'm showing common carotid on top, internal carotid on the bottom, and the vertebral. Here there's one abnormality noted in all the waveforms. What is it? What do you notice on all three waveforms from the right side? They all demonstrate a tardus configuration. Everyone see that? We don't have a nice normal rise. There is a delay to peak systole. It looks like a TP, tardus parvus. Okay? Now let's look at the left side. Again, common carotid on the top, internal on the bottom, and the vertebral artery. What do we notice here? A similar appearance. Although the velocities themselves may not seem completely abnormal, because we have 60, 40, and 54, what is the abnormality? They all have a tardus configuration. So, if we see tardus waveforms in all the vessels that we sample in the carotid and vertebral system, what's the likely diagnosis? Aortic stenosis, aortic regurgitation, subclavian occlusion, cerebral edema or mass, or bilateral carotid stenoses. What's the only one that makes sense? Aortic stenosis. We have an inflow lesion involving the thoracic aorta. It's affecting all the branches, both common carotid arteries and the vertebral arteries. Only one that makes sense. We confirmed it with echocardiography that showed there was aortic stenosis. So again, all the waveforms show a tardus pattern. We know the likely diagnosis is aortic stenosis. Next case. This patient has a history of a CVA. Okay, and we're looking at the left carotid bifurcation. So here's the distal common. Here's the internal. Do you see any abnormality? Looks wide open, right? Maybe there's a hint of plaque. Certainly doesn't look like there's a flow-reducing lesion. Now, here's the sample from the distal common. The velocity is 77. That's fine. What about the waveform? What do you notice? High resistance. Very good. So we have our normal systolic upstroke. The inflow is okay. But there's high resistance with reversal in diastole, suggesting that there is a distal lesion. So let's look at the internal. Here's the sample from the internal. The velocity is 25. The vessel's wide open. Where's the lesion? I can't show it to you. You have to tell me where it is. It must be distal. What has happened between the distal common and the left internal? We've lost velocity, and we've increased resistance. So the lesion must be downstream. But I can't scan any higher. I tried moving the jaw. It doesn't budge. Okay? So I have to order a different test to look at the internal. So if we're going to postulate where the lesion is, I'm going to say it should be in the distal ICA. Because even in this sample from the internal carotid artery, I have a nice normal systolic upstroke. The inflow is fine. It's just increased resistance to flow downstream. Again, normal color flow on the color display. The left common carotid artery showed high resistance. Increasing resistance and low peak systolic velocity in the internal carotid artery with a normal upstroke spells outflow obstruction. For this case, again, we ordered a magnetic resonance angiogram. The initial component showed that the ICAs proximally were fine, but there was a distal lesion in the internal carotid artery that was described as a supraclinoid ICA stenosis. So again, didn't have to see that stenosis to know that it was there. We did have to detect the abnormality in the visualized segments of the carotid artery to order the appropriate test to make the diagnosis. Okay, next case, history of right-sided weakness. Starting with the right side, proximal common carotid artery has a velocity, it's elevated, it's 158. Then we move into the distal common, it drops down to 73. See a little bit of thickening, some mild plaque, no significant stenosis. But we start to see marked thickening and plaque as we move into the internal carotid. Notice there's some narrowing of the lumen, and the velocity here jumps up to 178. And I think that's consistent. We see narrowing, the velocity is 178. It fits for me to be about a 50 to 69% lesion. Let's look at the left side. The left side starts out with a velocity of 69. And you might wonder if the resistance is a little bit increased. The external carotid has a velocity of 162. Now watch what happens as we move into the internal. We see a lot of plaque and irregular narrowing of the internal carotid. In fact, it's difficult to connect really the dots of the internal carotid. It looks patent but very discontinuous and irregular. The velocity in the left internal is 44 centimeters per second. And you can see I'm having trouble sampling the internal carotid. Okay? One more sample from the case. Here's the distal internal. The velocities are dropping to 11 centimeters per second. So there's marked narrowing, irregularity, low velocity. So how are we going to describe the left internal carotid lesion? Probably not significant, moderate to severe stenosis, near total occlusion, or I just can't tell. We'll get another test. Now sometimes we just can't tell. And some of these cases are difficult. We may not see the vessel well to be able to make a specific diagnosis. And even if we're suspecting the diagnosis in this case, it might not be a bad idea to get another test to confirm that. So let's analyze the case. The right side I thought was pretty straightforward. We saw narrowing, a velocity of 178. That's consistent with a 50 to 69% right internal carotid artery stenosis. On the left side, we saw incomplete filling of the left internal on the color flow image. Very low flow with a TARDIS waveform. Okay? The TARDIS waveform is telling us that it's not a distal lesion, that the lesion is either missed or it's at that location. So what do we think is going on? Okay? Well, we suspected that it was a near total occlusion because of the marked narrowing and irregularity and low velocity flow. We sent the patient for the MRA, which showed an extremely tight stenosis in that location in the internal carotid artery. Putting it all together, the tight stenosis, the low velocities, it's a near total occlusion. So again, reinforcing the fact you can have a very, very tight stenosis and low velocity flow. The key to the case, again, the marked narrowing on the color display. All right, you guys should be ready for this one. Here's a patient with syncope. This is the right internal carotid. Now, there may be just a touch of plaque in the internal. The velocity is 128. The vessel is wide open. Now, you'll say to me, well, what's going on in the common? Here's the common. Come on up. And the common carotid artery shows a little bit of thickening. The velocity is 191. Okay, so actually the velocity is going down in the internal. So although the velocity is over 125, we see no evidence of stenosis, and the velocities are actually downtrending. So it doesn't look like there's a significant lesion there. Why the high velocities in the right? Got to look at the left. Left side, we see a left internal carotid artery occlusion. This is the reversal of flow at the level of the bifurcation. There is no flow seen in the internal carotid artery. So, what are we going to say about this lesion? We're going to say that we don't see a stenosis. It's probably not significant, although the velocity is elevated. But as we mentioned before, when we see elevated velocities throughout the vessel on the side opposite a high-grade stenosis or occlusion, we say it's usually related to compensatory flow. So keep that in mind. Compare both sides, and when we see elevated velocities throughout the vessel, it's likely related to this mechanism. Next case. Here's a patient that presents with dizziness. The first sample from the distal right common carotid artery has a velocity of 120. Vessel looks fine. Velocity is borderline elevated. As we move into the internal, we see the velocity is 74. Okay, no stenosis there. Here's the left side. In the distal common carotid artery, the velocity also somewhat elevated. It's 126. We move into the left internal. It's 137. Here's a look at the left internal. Looks perfectly normal. No plaque. Normal color flow pattern. The distal internal is 105. So what do we do with a velocity of 137? In the absence of plaque, do we call a stenosis? Okay, that's the question. We could say it's normal, mild, moderate, severe disease, or near total occlusion. We have a discrepancy here. We have elevated velocities and a normal grayscale and color flow pattern. Okay? Elevated velocities are seen in both common carotid and internal carotid arteries. There's no plaque or narrowing on the grayscale. The ICACC ratio is about 1. So we have discordant criteria, and we have to be careful. We have to step back and look at it. I think it'd be very uncomfortable to say there's a stenosis there in the absence of any plaque or any color flow disturbance. And if you're unsure, you should ask for correlation. In this case, correlation was obtained, and we see from the MR a normal examination. Okay, we see that the bifurcation is fine, both on the time of flight study that is done on the left without contrast, and on the gadolinium enhanced study, we have normal carotid arteries. We just have elevated velocities in the absence of stenosis. This patient presented with a history of syncope. And we look at this left carotid artery, and we'll notice in the distal common we have a velocity of 80. In the proximal internal it goes to 58. And notice where there's a bend in the vessel, right here, we see a focus of aliasing. The velocity there is 158. So we're going from 58 to 158. We don't really see any plaque, just a focal area of increased velocity. Here's the right side. Peak systolic velocity in the internal is 77, and going back to that area in question, it's 158. So again, how would you treat this lesion? You're going to call it normal? Well, I don't really see much plaque there. Is it a mild stenosis? I've got a velocity of 158. Is it 50 to 69%? Is it greater than that, or do we call it a near total occlusion? Well, again, I think this is a situation you've got to take a good look at it. You have to take a closer look and say, what is going on here that's giving us this elevated velocity? We really didn't see any plaque. The high velocity is in an unusual location, right? It's not in the proximal internal, it's in the mid to distal internal carotid artery. In fact, it's in an area of tortuosity. It's in a region of a bend in the vessel. So we called it an area of kinking. And when we sent the patient for MRA, we were able to confirm that there was a bend in the vessel, likely causing a focal area of increased velocity. Yet it's not an atherosclerotic plaque. Next patient presents with a history of weakness on the right. Proximal common has a velocity of 37. Distal common is 38. And the ICA is 64. Relatively low velocities. We don't see a lesion. We go to the left side, and looking at the grayscale image, we see that there's focal calcified plaque that's occurring in the proximal internal carotid artery. The velocity in the proximal common is 43. In the distal common, it's 39. And in the region of the plaque, it's 182. So with a velocity of 182, focal plaque, we have our choices, less than 50%, 50 to 69, greater than 70, or just show me the MRA. Okay? Here's the analysis. Low velocity flow seen in both common carotid arteries, moderate plaque in that left internal with a peak velocity of 182. If we do the ratio, the left ICA-CCA ratio is 4.8. That suggests a pretty tight stenosis. Yet the velocity is 182. So again, we have a discrepancy here between the peak systolic velocity and the ratio. Of course, it's complicated by the fact that we have low velocity flow. In this case, we sent the patient for an MR, and it was read to be less than a 70% stenosis, probably closer to a 50% lesion. And the only way we put it together is really by correlating all the findings. By looking at the grayscale, looking at the color, saying that it looks like it's probably closer to a 50% stenosis than a high-grade lesion by looking at the grayscale and the color, because we had discordant Doppler findings. And of course, when we're not sure, the MRA helps us here because it shows us the lesion in the vessel. This patient presented with a history of stroke. Okay? Now this case is particularly tricky. I want you to pay attention to the waveforms. Looking at the case, we see that the velocity in the distal common carotid artery is 53. We have a sample from the external carotid, looks high resistance, 87. Here's a sample from the internal carotid, it's 75. And in the vertebral, we have a nice normal looking waveform, antegrade flow, it's 45. Anybody see an abnormality? High resistance. Someone points out that it looks like there's high resistance in the internal carotid. It's a good observation. Hold on to that. Let's look at the left side. Here we're looking at the left carotid artery. Distal common has a velocity of 64. There's the external high resistance waveform, 96. Here's a look at the internal carotid on color. You can see that there's some plaque, narrowing, aliasing. Notice where I placed the sample volume along the course of the jet, along the anterior wall, angle corrected to the direction of flow. The velocity there, 273. Okay? This side, we clearly see that there's a stenosis there using peak systolic velocity criteria, should be greater than a 70% lesion. So, what are you going to put in your report? What's your suggestion? Right ICA occlusion, left ICA stenosis, both 1 and 2, or wait a minute, did I miss something here? I didn't think there was a right internal carotid artery occlusion. We saw the right internal carotid artery. But the observation we made was that the right internal carotid artery looked like it was high resistance. Okay? So the right internal carotid is showing us a very high resistance pattern like the external carotid artery. If we look at that bottom image, you have to say to yourself, does that look like a normal internal carotid artery to you? What's the problem? Looks small, right? And in fact, even the external carotid artery looks kind of small, all right? And they both show high resistance waveforms. Both vessels are small in caliber. In fact, both are branches of the external carotid. The right internal carotid artery was never visualized. It was misinterpreted as being a branch of the external. And this was confirmed at arteriography, where they show that there is no right internal carotid artery, just branches of the external. They also confirmed that there was a high-grade stenosis of the left internal carotid artery. So we have a right ICA occlusion that was missed and a left internal carotid artery stenosis. Okay? So the take-home point here is we not only have to look at the waveforms, but we also have to look at the vessels. Both of these vessels were small, had high resistance waveforms. We were really looking at branches of the external. Okay. Here's a patient with a history of stroke. Another difficult case. This patient has an occlusion of the left carotid. Well seen. We can see that the left internal carotid is filled with plaque. There's no color flow signal. And when we sample the left internal, there is no flow. And we interrogated throughout that portion of the vessel. Now let's look at the right side. The right side has an irregular appearance. We see irregular calcified plaque along the wall, and clearly there's an area of focal narrowing in the internal. We turn the color on, and we can see that there's aliasing at the site of the calcified plaque. And the velocity there is 238 centimeters per second. Okay, so let's step back and think about this. We see calcified plaque, we see narrowing and aliasing, the velocity is 238. We know the patient has a contralateral occlusion. We also remember, while you can have compensatory flow opposite a stenosis or an occlusion. So how tight is this stenosis? How significant is it? Well, we need to know what the common carotid artery is. The common carotid artery in the site is 53 centimeters per second. So the ratio is greater than 4 to 1. So we have high velocities and a high ratio. It should be greater than a 70% stenosis. So if we try to consider what the degree of stenosis is, we have two pieces of information that suggest it's greater than 70% stenosis. And yes, I want to see the MRA also. So analyzing the case, again, narrowing on the grayscale and on the color display, high peak systolic velocity, high ICA to CCA ratio greater than 4 to 1. So we lean toward it being a significant stenosis rather than just being related to compensatory flow. Here is the MRA, which shows the occlusion on the left side and the high-grade stenosis on the right, considered greater than 70%. So with that, I conclude that even when you have a difficult case, you really need to take into consideration all the pieces of the puzzle. Look for the presence or absence of plaque. How much plaque is there? What do you think is the residual lumen when you reviewed both the sagittal and the transverse views? Integrate both the peak systolic velocity and the carotid velocity ratio information, as well as the shape of the waveform. Always compare it with the opposite side, and by putting it all together, it should lead you to the correct diagnosis. Thank you.